Firstly, welcome. Thank you for joining in. It seems like we've been doing these on via Zoom now for an absolute eternity, and it's only 18 months, but never mind. I'd like to welcome Professor Adrian Newland, who will be answering your questions today. Adrian, as you probably know, is the Chair of Trustees of the ITP Support Association. And I'd also like to welcome and introduce Mrs. Rhonda Anderson. Rhonda, as you would have probably read in the Platelet, is also a senior patient mentor. Now, to kick off, I've got a couple of questions that have come in. If I can just ask, if anyone isn't speaking, if you could just mute your audio so we don't get any background noise, it's then better for the people watching. And if you do want to ask a question, just put your hand up, just like that, and then then we go from there. Okay, right, got one from Tina Fry up in the northeast. Hello, Tina. She's asked, could Professor Newland explain to us the various factors that can influence one's platelet count? And the reason she's asking is that she recently started on romiplostrin, so her platelets are checked weekly to work out the dosage. A few weeks ago, her platelet count plummeted when huge amounts of pollen were blowing across from the local fields of the oilseed rape. The following week, after a downpour of rain, my platelet count was bounced back to a higher than it was before. I also have hay fever. Could the pollen and hay fever reaction have triggered my immune system to start destroying extra platelets? Adrian.
Yes, that's a very interesting question. And I don't know the full answer to that, but what I do know is that you can react to things in the environment and will affect your platelets. I remember quite some time ago now, a young woman who went into hospital to have a splenectomy for her ITP at the time when we did more splenectomies. And while she was in hospital, her count came back to normal. So the operation was suspended and she went out again and her platelet plummeted. And so it was discussed with her what she was doing. And she was a demon for McDonald's burgers. And she actually reacted to the sesame seeds on the bun. And so the experiment was done where she stayed off them for a bit, and then she had the sesame seeds, and the count plummeted. So you can actually react to things. I suspect it's probably something related, that sort of reaction is related to the pollen, and that you've inhaled it, and your body's reacted to it, and that's in some way it's your body in producing antibodies to the pollen. Those antibodies also react with the platelets and they drop. Now, as soon as you stop challenging yourself, and obviously you didn't challenge yourself, the pollen did, but with the rain, when it damps the pollen right down and it's not in the air, you're not breathing it anymore, and the count comes up. And that's the only explanation I can think of for that. And it's quite fascinating. I've come across very few people who've had that sort of reaction at all, but it seems that we know that with the oilseed rape, you can get a lot of pollen in the air at the right time. I mean, I don't suffer from hay fever, except very occasionally at the height of the season, my nose will run. And I remember once going to a meeting that was held down in Brighton on the Sussex University campus. They'd got lots of trees, and I walked onto the campus and immediately started sneezing and my nose started running. I went down to the beach and it all stopped. So I think you can respond to that in extreme circumstances. I suspect there was just a lot of pollen in the air, and that was what you responded to. But it's and it can be so marked that it can overcome the impact of the romiplostin pushing your count up. I mean, the other thing that we occasionally see, and obviously if you've been on romiplostin a while and and the count is up and responds. Some patients on ranitidine have their count go right up in the days after the injection, and then it drops right down again very quickly, and then goes up again. We sometimes see that sort of wild fluctuation with ranitidine, and however we deal with the doses, it's very difficult to prevent that happening. But I guess if you've been on ranitidine a while and the count's otherwise fine, and it just happened this once with the with the pollen from the local fields. I suspect that's what it was, but it's very interesting. Very interesting.
Okay, anyone else got a question before I move on? Diane, you got your hand up?
There's a
You're
hand up
muted,
there.
Diane.
Christine has a hand up.
Did she? Christine as well. I'll go for Christine afterwards. Diane?
Yellow.
You're muted, Diane.
You have to unmute.
Okay, we move on to Christine while Diane's sorting out. I've never known Diane be short of words, but never mind. Christine.
Hi everyone. Yeah, been on romiplostin now for about 10 weeks. So I started on 60 milli whatevers, and I'm up to 480.
Yeah.
And my platelet count can just, and it always has been, and my consultant keeps telling me it's really strange. Last week it was 201. Today it's 8.
8, yes. Well, that was what I was saying to Tina.
Yeah, I'm also on, I'm still on my steroids. So
Yeah.
I'm doing this balancing act between, I have been on as much as 30 milligrams of steroids. I've been on 5 milligrams for the past 2 weeks. And then today I've had to go back up to 40 again because my platelet count's dropped to 8.
Have you had any gaps in the ranitidine, or are you still having a weekly dose?
I'm having a weekly dose, and each week I started off on 60, so I've been raising it. So I've got another 2 weeks left until I'm up to the amount that I can have for my sort of weight, which I think is about 600.
So they haven't dropped any weeks at all, because sometimes it goes up. Some doctors higher than yours has been. They'll stop it, miss a week, and then that causes it to plummet. But a small
the highest is gone. I think it was 240, 248-ish, nearly new to 250.
Which is a very reasonable level. It sometimes does that in the week. When you go to the dose for the next week, your blood has gone straight up and come straight down. We often, if you're one of the sort of 10% where that happens to, I think there are a number of options, and having a small dose of steroids with it, because steroids stop the platelets being destroyed, and obviously the ranitidine is pushing the platelets up. So sometimes if your body is destroying them quite quickly, it starts destroying them as the effect of the ranitidine wears off. So we often give us a continuous background dose of steroids that doesn't have to be as high as 40, it can be 5 or 10, and just see what things.
Yeah, which was what I've done for the past 2 weeks. Yeah. So it was something like 60, went to 100 and something, went to something, and then like I went this morning and it's 8 again. So she just said we need to go back on some steroids, and
I mean that's reasonable to push it up. We sometimes then, instead of using the steroids, substitute the drug mycophenolate and have that, because that also impacts on that.
That's
if it's
yeah.
If everything.
Sorry, that's the next thing. That's the next thing she wants to try. She doesn't think the romiplostin is going to work, so she wants to try mycophenolate.
Well, it clearly works because it's put your count up. It's a question of if you can keeping up, and sometimes adding the two together helps that because they work in different ways.
Oh right, so you can. Because she was thinking if the romiplostin doesn't work, she's saying, I don't think it works, you should do mycophenolate instead. But you can do the two together, can you?
We would add the mycophenolate to a dose of the mycophenolate to the ranitidine, because you're clearly responding to the ranitidine because your count's gone up to 250.
Yeah.
The other option is to switch thrombopoietins completely and go on to eltrombopag.
Yeah, I tried that. You're really ill.
Did it? Okay, because I was going to say that's a daily dose, so that's often dose.
It made me really ill, but it also didn't work. So I was really ill and it didn't work.
Well, that's why we have lots of different options to try them.
Yeah.
Okay, well, let's see how it goes.
Okay, brilliant. Thank you.
Thank you, Christine. Right, Diane, are you there now?
Hi, I'm back. Vocal.
Okay.
First of all, yeah, I get that real sort of roller coaster with romiplostim, and I'm on the highest dose. And my roller coaster, really, the day after, weirdly, is the day that I am absolutely flattened, and then I get a day up, and then I get another day down. So it's very weird, the fatigue particularly. But just going back to this issue about possible allergic reactions, I'm doing a little bit of an experiment at the moment because I thought maybe food had an impact. So about 2.5 months ago, I got rid of, I'm not suggesting anybody try this at home, this just seems to be maybe working for me. So I cut out wheat and dairy and gluten, and for the first time my count went over 50. Now I've got another count on Monday, but it does seem to be working, and I think there is a little bit of evidence that some foodstuffs can be irritants to the body. They're kind of inflammatory almost. I mean, obviously I'm doing the sensible thing, and I'm having other things in there, plenty of protein and what have you to replace. But it is quite interesting. I suppose personally I'm looking more and more in the direction of certainly irritants or allergic reactions in the body causing this, whether it's pollen or whatever.
Yeah, I have to say, one of my American colleagues who has a lot of interest in ITP and has published a lot on it, one of his team did a big review of all the publications on foodstuffs and low platelet counts and could find no consistent association whatsoever. There's a potential that actually, particularly in processed foods, some of the preservatives and some of the additives are what people react to. So some of the colorings and some of these odd E numbers and things that you find in foods. I know quite a lot of patients who've tried various exclusion diets, and in some it seems to work, and in others it has no impact at all. And all I would say is you find what works for you, and if it actually has worked, then that's great.
Well, I mean, the sort of jury's out at the moment, Adrian, in all fairness. I mean, I'm following not an exclusion way of eating. I'm actually following something called the wall protocol. I've spoken to Mervyn about this before. So I'm eating a massive range of vegetables and fruits in with my diet, along with organic fish and chicken and so on, to see if that makes any difference whatsoever. But it is absolutely horses for courses, and we've all got to try and find out what works for us.
Well, I would say what you're eating is good for you.
Yeah, I mean, I've never, I don't eat any additives anyway. So,
I mean, irrespective of what it's doing to your ITP, it's actually quite a healthy diet.
Yeah, absolutely. I'm trying to get 10 years younger, but it hasn't happened yet.
Yeah,
Okay,
could
thanks,
I
Diane.
come in there, Mervyn?
on,
Could
Robin.
I come in?
Yeah.
Diane, I hope that works for you. It's a very interesting thing. There is the old saying, isn't there? You are what you eat. And of course, if we eat a lot of rubbish, which unfortunately some people do, then it's not going to be good for you. And a healthy diet is always recommended for absolutely everything and anybody. I just wanted to make the point about allergy and intolerance. I have a history of serious allergy in my family, and an allergy is something that is very severe. So you would perhaps get anaphylaxis with an allergy, so that this is when the whole body starts to close down, you get breathing difficulties, and unless you have adrenaline or something administered straight away, you would then possibly die. So that is an allergy, a true allergy. An intolerance is what some people may get if they eat, say, for instance, strawberries, and they come up in a bit of a rash, or they eat something that gives them diarrhea or stomach ache, or they put it in their mouth and they get a tingling feeling and nothing more than that. So I think it's really important that when we're talking about allergy and intolerance, that we actually get that right, because an allergy is very serious. My daughter had anaphylaxis at 4 days old and she was 5 weeks premature. And that was from having cow's milk in the baby formula. And I have allergies myself. I'm very allergic to fish. I never touch anything that's fish or that comes out of the water because I do actually have an allergy. Whereas I have intolerance to some other things which I avoid, such as nuts. So I can eat nuts, but I wouldn't eat many nuts because, you know, I know that they don't do me any good and I generally avoid them. So, I mean, I just wanted to make that clear to people who perhaps haven't had any experience of this before. But I think the thing is that we always say is if you find that something works for you, then as an individual, then, you know, stick with it as long as you're having a balanced diet.
I mean, I was actually getting incredibly bad asthma when I ate bread or dairy or gluten, you know, wheat.
Yeah.
I mean,
Yeah.
I'm not using an inhaler anymore. I'm getting the itching and you know, the whole sort of allergic reaction. So clearly there may be something in it.
Yeah, that is great. And it's dairy products have been associated with asthma and catarrh and chest problems for a long time.
Yeah.
Okay, thanks, Diane. Thanks, Rhonda. Before I go to some questions from Peter, Valerie, you had your hand up.
Right. I should be unmuted now. I was just going to say it's my daughter that's got ITP, and she had been on, she's only 27, she'd been on mycophenolate mofetil for about 2.5 years, and because she's a young woman, we were a little bit concerned about that for her. So last August, we took a bit of a leap of faith. And I'd been talking to somebody in America who'd actually overcome ITP. And basically what she did was it works on the basis that your body is actually fighting a virus. And that's why it inadvertently attacks your platelets by mistake, if you like. And what we had to do was remove any toxins from the environment, and that is quite significant. So things like plastic, cleaning items, shampoos, anything that you use on your body, makeup, etc., cooking utensils. So it was quite a big thing to do. And then Caitlin did a 28-day detox diet, which was very strict. And bearing in mind she's a vegetarian anyway, it was even stricter. And then we gradually reintroduced things. And my point being that when she was on MMF, her platelets never got above 80. And they often dipped down and got closer to 50 and I think even below that at one point. But what has happened in the last 11 months is they've gradually increased. Now, the last time she had a check was late May, and they were 105. She's now on 6 monthly checkups. So, you know, it seems at the moment that it may be working for her. And her haematologist is very pleased with her. So there may be something in what you're saying, Diane. It's not necessarily just food, it's about the environment. As much as you can, trying to get rid of the toxins, because the theory is that the virus actually feeds off the toxins and certain foods. And there's so many toxins in the environment at the moment. You know, it's not just on our food, it's everywhere.
Yeah, I mean, you know, I was pointed in the direction of a protocol that American professor has written a book about, and she had proper research funded in the States, and she had MS, and while she hasn't cured herself, she's out of the wheelchair, she's doing sport again, and so on and so forth. So it's more about, you know, the immune conditions, really.
Yeah.
It's really similar to what you're saying, except obviously
Yeah.
I wasn't on a detox or anything, because I wasn't eating processed foods, etc. But I have really gone organic. I won't buy vegetables and stuff from a supermarket now. I'm buying them at farm shops and what have you. So I think, I mean, again, it is absolutely horses for courses, as Rhonda says, but
Yeah.
I think there is quite a lot in this, in what you're putting in your system and how your body is reacting to it. Because I was getting terrible itching all over when I was, you know, after I'd eaten, and also up until about a month ago, I was bleeding every night. There was blood over my pillow every night, but it's gradually, it feels a bit better.
Good.
See, it's early days.
There are some, there's some publications of one-off cases, particularly in people with other generalized disorders like MS and chronic fatigue, that a severe restriction diet over a period of a few days it improves people. No one knows why. It's not been done in any major scale at all, so I'm not necessarily recommending it. But what I'm saying is I'm agreeing with you that there are some things that happen. I mean, my son-in-law, who doesn't have ITP, I have to say, but actually had quite a lot of issues. We found he was allergic to mustard, to sulfites, and also to gluten. And although he had the test for celiac disease, which he doesn't have, but when he went on to a gluten-free diet, he lost his irritable bowel syndrome. He's lost all the other problems that he had. So there are things in diets. It's an area that we don't look at very carefully. The ITP Association did some years ago fund a professor in Addenbrooke's, who's a gastroenterologist, who was looking at diets and was measuring platelets and measuring various things. But unfortunately, despite the fact that he did this very vigorously, he could find no association between things in the food at all, but the numbers were small. And an ITP is such a variable condition, people are so different that that you can look at 20 or 30 patients and that you may just miss the one in whom that would have been an important part. So I wouldn't say it's wrong to do that. I wouldn't necessarily recommend it. I would say that people should eat healthily, and clearly Tina is, and Valerie's daughter is. Whether that's an impact on the platelets, I can't say, but it's certainly making you feel a lot better, and that's important.
Yeah, I mean, I'm not on any kind of exclusion. In fact, you know, probably eating a much more varied diet than the majority.
Okay. I've got some questions here from Peter Moyston. Peter, would you like to read your questions out, Peter, or would you like me to read them out? You're on mute, my friend. You're muted, Peter.
Peter, you're muted. We can't hear you.
Peter, you're muted.
Shall I've got his.
Right. Okay. The question is, this is from Peter. I'm a 76-year-old male, lucky enough to have a platelet count which has declined only slowly and smoothly to the current low of 90 from the 131 when it was first diagnosed in 1988. The bone marrow test some years ago showed that I am generating platelets as I should, but my immune system is attacking them. Needless, would I be correct to assume the following? My ITP means I have an autoimmune disease. 2, this probably places me in the 5% or so of 2 Pfizer jabs recipients who are not as well protected as a 95%, I don't know, to the extent of which I'm less protected and the consequence is unknown. 4, the amount of protection for ITP patients may or may not diminish in line with the platelet count. And 5, this is an interesting one, if and when I'm offered the third jab, the so-called booster jab, later in the year, should I insist on the Moderna vaccine? What is your guidance?
Well, that's an interesting set of questions. Yes, Peter falls into the 40% of patients with ITP who've never required treatment. We have to remember that 40% of patients with ITP never require treatment. We've seen that. We see that in our registry where we've got over 4,000 patients on it now. We did a study some years ago now in several centres in Europe looking at all the patients who presented over in a year, and 40% in both of those have never required treatment. Now, ITP is an autoimmune disease, but ITP itself and an autoimmune disease doesn't stop you reacting properly to a COVID vaccination, or indeed any vaccination. You'll respond as well if you have ITP to a COVID vaccine as the person who lives next door who has no ITP and no autoimmune disease. So ITP itself does not stop you reacting properly to vaccinations. When you may not respond properly to a vaccination, if you're taking steroids in a dose of over about 20 milligrams a day, or if you're having one of the other immune suppressive drugs, those are the indications where you may not react as well to the vaccines. Now, so Peter's chance of being protected by the vaccines are exactly the same as anybody else's, as he's had no treatment. So he's not in the small percentage who don't respond to the vaccines. As we all get older, our responses to vaccines are less vigorous than they were when we were younger. But the studies looking at both the AstraZeneca vaccine and the Pfizer vaccines have shown very good protection at over 90% in both. And so from that point of view, I wouldn't worry. I think the issue of taking precautions, I have to say, I still wear a mask if I travel on public transport. I tend to put a mask on if I go into a shop. I never wear a mask when I wander in the street because there's no evidence that people have ever passed on COVID by passing someone in the street. Someone would have to cough in your face who got active COVID to infect you. You don't pass it by walking past someone. You've got to be in someone's proximity for 10-15 minutes before you have any chance of passing it on. Now, the issue, and there's no association of response to the level of platelet count either. You can respond just as well with a count of 20 as you can with a count of 50, as you can with a count of 250. The issue is if you're offered a third jab, what should you have? Now, if you look at the data that the MHRA publish on a monthly basis from the yellow cards that are sent in having reactions, normal people can have a platelet response, have a platelet count fall with a normal vaccination. I mean, we know from the children's vaccinations that about 10 in a million children will have a platelet count fall after a vaccination, MMR in particular. This is usually transient, it's usually mild, and it usually doesn't require treatment. What we've seen a similar response to both of the vaccines in this country. For the Pfizer vaccine, it's about 7 in a million. For the AstraZeneca vaccine, it's about 20 in a million. These are in normal people. The Moderna vaccine's only been given to about 1 million people in the country, and there've been no instance of thrombocytopenia so far, but that's the small number. Now, if you consider that the incidence of ITP is 6 in 100,000 in the population, that's 60 per million. So in the first 6 months of this year, I would have expected 300 patients to present, 400 patients to present with ITP in the normal population. Now, looking at the figures from the 22, I was just looking at my figures from the 46 million people who received the AstraZeneca vaccine. There've been 1,000 instances of thrombocytopenia. From the 32 million who received the Pfizer vaccine, it's been about 226. So the numbers are different. Now, none of those figures, when you look at them, have produced as many patients with thrombocytopenia as would present with ITP in the normal 6-month period. So now you could say that's pure chance. Now, I don't believe that. I do believe that some patients do have a reaction to the vaccine and drop their platelet count, but it comes back up again. Now, we also know that 30% of adults with ITP are picked up incidentally. You have a blood test, you go for surgery, and you're found to have a low count. There's never caused a problem, and you've never bled from, and you'd never know about it if you didn't have a count. And like Peter, he's never required treatment. Now, some of those patients whose counts fall may well have had underlying ITP, but I do believe that vaccinations will cause the platelet count to drop in some. But of course, when patients with COVID, around 30 to 40% will have a low platelet count. And if your platelet count falls because you've got a severe infection, then your outlook is much worse. So I don't think the risk of a potentially reduction in the platelet count should stop you having the vaccine, because the risks and benefits, the benefits far outweigh the risks. And we know that the count, if it does fall, falls temporarily. We know of a couple of patients with ITP whose counts fall and who've required treatment to bring it back up again, but it's bounced up very quickly. Patients with ITP who have the vaccines, we know that their counts will fall. It's about 10%, 10 to 15% of patients with ITP have a fall in their counts. This is from the survey that Mervin's been running through the association. Again, the risks with the AstraZeneca vaccine are greater than the risks with the Pfizer vaccine. So yes, I think if any of you are offered a booster vaccine, which I'm sure that they will offer older and vulnerable people from the autumn onwards, you should want the Moderna or the Pfizer. I'd be very happy to have either of those. I mean, I had the AstraZeneca vaccine for my first and second, and I don't really mind which one I have when I have my booster. But I think if you've got ITP and you have a choice, you should ask for the Pfizer or the Moderna vaccine. So I think that probably answers most of your questions, Peter, does it? If not, if you've got any other things, then please ask.
That's very good, and I've jotted all that down. Thank you very much. As Mervyn knows, I've got a set of more sort of very personal questions. Am I in order to read that set of questions out, Mervyn?
Yeah, you can. Yeah, go.
And I hope nobody else has got this problem. So I'm going to read I'm going to read my question, if I may. Since my count has been 90, I have had surgery only once in 2015, and that was to core out my, this would be very boring for most of the people here, to core out my benign prostate whatever is it called, my prostate using a laser, a HOLEP laser, not a green light laser, but a HOLEP laser. There was a debate beforehand as to whether I should be given tranexamic acid after the HOLEP. And one hematologist had said yes for a TUR patient with ITP, but it caused in that patient such blood clotting that the patient needed to return to surgery for the clots to be cleared. In my case with the HOLEP, another hematologist and indeed ITP's medical advisor said I would not need tranexamic acid, and thankfully both proved to be correct. The bleeding was adequately controlled as intended by the HOLEP laser. So that's my history of surgery since I've had a count of 90. But
can I comment on that before you go on to the next bit?
Yes.
For those of you who don't know, tranexamic acid is a drug that helps consolidate clots. So it stops the body breaking clots down, so that when you've got a low platelet count, if you're starting to develop a clot and you continue to bleed, you may wash it away. So the tranexamic acid actually helps the clots to form and to become much more fixed. Now, a platelet count of 90 in terms of stopping you bleeding is completely normal. There's nothing else needs to be done that wouldn't be done to someone with a count of 150 or 250. So the second advice was clearly right. And what tranexamic acid can do, as happened to the other person, is it can cause the blood to clot, can cause the blood to clot in the bladder if you bleed from a prostate, and instead of peeing it out, it clots and can be very painful and may require further surgery. So it was actually spot on for that.
Thank you very much. May I then move on to the more serious surgery, which I'm threatened with, is that's open heart surgery. What I've got is a dilated aorta root. In other words, the root of my aorta, where it's attached to the aorta valves, instead of being 25 to 30 millimeters diameter, is currently 45 millimeters. And although there's nothing wrong with my aorta valve, it's not calcified, the aorta root is stretching the aorta valve and causing severe aortic regurgitation. And if I don't have the surgery, the consequence is that I could end up with heart failure, which is obviously irreversible. So my first question is, what extra challenges might the cardiac surgeon face because of my ITP?
Well, our advice on levels of platelet count for surgery is that with a count of 90, nothing extra needs to be done. You will stop bleeding, just as someone who is normal would. Now, of course, you're taking a drug called apixaban, which actually affects platelet function, which is a drug that it's an anticoagulant that we recommend for patients who may have a thrombotic risk. In a count of over 50, we're happy for patients to take that without worrying about bleeding problems at all.
Good.
So my advice is there that the surgeon would do exactly what he was going to do normally, both with the apixaban and we sometimes use heparin to cover surgery because heparin can be stopped immediately. And they would usually use that for the period of surgery. That the surgeon could go on and do exactly what he needs to do for your aortic surgery without having to worry about the ITP.
Tremendous. Thank you. That's very, very reassuring. That's clobbered the next question. And I dare say it also clobbers the next one, which is that prior to the open heart surgery, I've got to have preceding tests such as a TOE and invasive coronary angiography. And I presume that, again, because my count is 90, that I should be treated as normal as if I didn't have ITP.
Yeah, absolutely.
Good. The final question is, I think I can anticipate the answer. Should I also, because of ITP, be wary of an increased COVID risk and its complications connected with these tests and the operation and with any aftercare? Am I at greater risk? I mean, it seemed to me I'm at greater risk if I catch COVID. That's perhaps what I'm more worried about because I've got a precondition.
Yeah, you're at a greater risk because of your age.
Ah.
That's the main thing. The only risks from surgery are the risks of being in hospital and risks of catching COVID within hospital, in all honesty. So it's a question of having a discussion. I know within my own hospital, at Barts, we have one hospital where no emergencies go in and no general people go in, and that's where we do the cardiac surgery. And that's a completely COVID-free hospital. So a hospital like that you'd go into and not worry about it. If the surgery is done in a hospital where there's still COVID on some of the wards, there's always a risk. And that's a discussion to have with the surgeon.
Thank you. Thank you. The final thing that I wrote to Mervyn was really an offer, which is that because my hospital where the cardiologist is, who's excellent, is Queen Elizabeth Hospital in Birmingham, Dr. Lester is there. And I had a meeting with Dr. Lester a few years ago. And as a result of that, I was lucky enough to go on to the 100,000 Genomes project.
Mm.
And I've been told that Genomics England team is ready to start analysing what they call additional findings. And I wondered if you would like me, or whether the association would like to ask if ITP could be included in the list of what they call genetic glitches there are they say 13 glitches in the list so far, but ITP does not seem to be amongst them.
Well, we haven't tried to persuade them for quite a while, but they haven't accepted ITP as something to look at. That's something that we're also planning to look at through the ITP Adult Registry. We now have nearly 4,500 patients registered on the books and well over 2,000 samples of DNA stored there. We were told when we set this up that you need at least 2,000 samples of DNA before you could actually find anything, because ITP itself is such a diverse disease. People are so different. You know, why do some need no treatment? Why do some just respond to steroids? Why do some need to have their spleen removed? Why do some need immune suppressive therapy? So there are all sorts of different cohorts, and we were told we'd need at least 2,000 to look at to start to marry up with the clinical data to see if we got anything worthwhile. Now, clearly, if we could get data through the genome project, if enough people with ITP on it that we could actually get it looked at, then that would be very interesting. I mean, any source of good data would be good. The person who runs the genome project is actually a colleague of mine at London, Mark Caulfield, who set it up initially because he was doing similar studies in cardiac disease. And again, they were doing in conjunction with some Scandinavian groups because they needed so many people to actually find anything worthwhile. But even that close proximity wasn't able to persuade them to include ITP, but there's no reason why we can't go back. I mean, they have so much data stored there. There must be some fantastic things that are tucked away in their terabytes of information that they've got tucked away in their massive computers. But yeah, you can try. We'll try. Yeah.
Okay.
Thank you very much, Peter. Thank you.
Thank you very much. That's been ever so helpful. Thank you.
No problem at all. And Christine, you got your hand up again? Got another question?
Yes, I have again. Sorry.
All right.
Going back to the vaccine.
Yeah.
I had my first one.
Yeah.
And my platelet count did drop on the time. There'd been a bit of a muck up, shall we say, in the nicest possible way with my platelets. And unbeknown to me, I was taking about 120 milligrams a day when I should have been on about 25. But anyway, and my platelet count did drop, but it didn't drop substantially because my platelet count is going up and down. And I'm still on the steroids and the romiplostin. My consultant has told me that I am not allowed to have my second vaccine.
Oh.
So I haven't had it. I'm not happy not to have it.
I can see no reason why you shouldn't have your second vaccine.
She said it'll, because I had, what did I have first time around? Not the Pfizer, the other one.
The AstraZeneca one.
I had AstraZeneca first time around.
Yeah.
So would you advise that I go back to her and say, can I get the Pfizer and can I get that as soon as possible? She said all the time you're on steroids, I don't want you to have it until your platelet count is stable. Hasn't been stable now for 2 years. So.
Well, I don't think your count doesn't need to be stable. It would be nice if your count was if the steroids were under 20.
Right.
If you have the injection in the few days after, if you have the vaccination in the few days after you've had your romiplostin, then that's fine. Your count will be gone up anyway.
Right.
And it only needs to be up for the sort of 24 hours of the vaccine. And anyway, we've had people vaccinated with counts of as low as 20, and we just ask the vaccinators to use a smaller needle and to press on it for 5 to 10 minutes afterwards to make sure there's no bleeding into the muscle.
Right. But the Pfizer would be better if I was to do that, to ask for that one.
It probably would, yes. I would suggest that now. But there's really, the benefits of 2 vaccines are so much better than just having the one.
Yeah.
One should you should always be trying to have both vaccines.
Right, okay. I shall go back and tell her what you said. Thank you.
Thank you very much, Christine.
I'll expect an irate phone call.
Okay, there's another question here. Rhonda, you had a question about the shingles vaccine. I know you've spoken to Adrian, but
Yes, I did. I thought this might be interesting for people who are over 70, because GPs now seem to be quite keen to phone their patients to get them vaccinated with all sorts of things, not just COVID. So my GP got in touch and offered me the shingles vaccine because I'm now 72. And in the past, I was told by my GP not to have it because I have had a splenectomy. But I'm not on any treatment now, and I am well, generally speaking. So I actually asked Adrian if I could have it, and I did look up the information on the ITP website, which also points you to the NHS website on shingles vaccine, and I've read them both up, and I worked out for myself that it was fine for me to have it. And as Adrian rightly pointed out, shingles is a very nasty disease to get, especially if you're over 70. And to have the shingles vaccine would be a good thing. So I am actually going to, I only, have all this information sort of as of today. So I am going to get in touch with my GP and say, yes, I will go ahead and make the appointment. I think that people, would be interested to know that. And as Adrian says, and he'll correct me if I'm wrong, when you have an injection, sometimes it can bleed, you can get a bruise. I actually got a bruise from my pneumovax, even though my platelet count is about 300. So, you do sometimes get a bruise from a vaccine because it is obviously an injury to the skin, and people can bruise whether they've got low platelets or not. But yes, so thank you, Adrian. And if you want to add to that, please do.
Oh, I'll just reiterate the point. Shingles, as you get older, can be a very nasty disease, and you're more prone to get it as you get older because your immune system is less active. So even if you had shingles as a child, getting a boost here does no harm. Without wishing to give anything away, I'm having mine next Wednesday.
Yeah, it's chicken pox as a child.
Yeah, well, you could have chicken pox and then shingles. So shingles is where it's the chicken pox, but it's confined to an area around your chest, but particularly it's when it affects the face that it's particularly unpleasant, and it can do. It commonly affects around the eye area. So I would strongly recommend anyone of that age to have their shingles jab.
Yeah, well, I expect a lot of us have had chicken pox, but children don't normally get shingles, do they? It's usually older people.
I had shingles when I was in my very early teens.
Really?
Yeah. I remember my mother painting collodion on it to stop me scratching it.
Yeah.
Well, I think both Peter and Valerie are saying they've had.
My eldest daughter had shingles when she was 3. I had chicken pox when I was 12 weeks pregnant with her. So I said to my GP, oh, that's all right. She won't get shingles when she's older then. And he said, no. He said, yes, she can get shingles again. Yeah. And then he said, but she won't get chicken pox. And the first week at school, 5 years old, she came home with chicken pox. Yeah. So
you're getting chicken pox would only protect her for 6 weeks or so post birth. It wouldn't give her any immunity.
Yeah.
And Peter, you were the same?
We had a couple of hands up.
Yeah.
I had my shingles jab about 4 or 5 years ago. Do I need a booster?
No, you don't. GPs are keen to give it because they get paid for it. They'll no longer syringe out your ears because they don't get paid for that. They'll send you off to the hospital.
Okay, Sue, you got your hand up?
Thank you.
Thank you, Peter. Sue?
Yeah, I'm someone who developed ITP after having the AstraZeneca jab in February. So I'm quite new to this. Without going in all the details, but my count dropped to 5. Then when I had the Pfizer in May, it dropped again. But I noticed, Professor Newland, you were saying a number of people with COVID, vaccine-induced ITP recover over a period of time.
Yes.
I mean, I've been very sensitive to romiplostin. I couldn't get on with electropobag, and I'm very sensitive to all of them. But I'm now having 2 weeks off. I'm managing. I've actually got up to 100. So I'm a bit hopeful that I'm suddenly at 5 months entering this period.
Well, if you're off all treatment, your count's 100, then hopefully that's going in the right direction.
Yeah, I was going to say I've got 2 weeks, but it was this whole thought of a booster and going through the roller coaster again.
Yeah.
Okay.
Well, yes, that's good. I'm pleased that's picking up, but it's important you've had the 2 jabs, I have to say.
No, I was just wondering, I mean, I'm getting the impression that a number of people on this call have been living and managing their ITP for a number of years. When I first looked at the yellow cards, there was only about 34 cases when I was there. It's very interesting to see how much they've grown.
Yes, but if you consider that we've now had 80 million doses of one of the vaccines being given in a 6-month period in this country, you would expect a very rare side effect to show up, because you've got such a vast population who've been immunized.
Yeah, and that has been one of the things I've tried not to talk about what happened to me too much, because I wanted people to go and have their vaccines. But it was also interesting on the sensitivity. I'm someone with a number of intolerances or sensitivities to things, so perhaps it's something to think of to reduce some of those. Thank you for your comments, everyone.
Thank you, Sue. Bonnie first and then Mandy afterwards. Bonnie?
Hiya. It was a question about different triggers that make our platelets go up and down, because I'm a bit of a roller coaster. Sometimes I usually hover around 30, but then I'll drop to like 8. And I think there's a food reaction, but I can't work out what it is. So I'd be really interested to know who the consultant is in America and the diet, for example, but maybe someone could pop that in the chat for me. But the other thing was about stress and like emotional kind of anxiety and things like that, and whether or not you find sort of anecdotally that people platelets drop at times of anxiety or high stress. I don't know whether, Professor Newland, you have found that people make comments around that and platelet drops.
Yeah, I mean, emotion, there's no doubt that emotion and stress can impact on your immune system. In fact, some levels of some types of stress actually put your platelet count up. So the sort of fight or flight reaction that people have, where you push out lots of adrenaline, you push out steroids, actually puts your platelet count up. But there's no doubt that sort of long-term low-grade stress can actually impact on your immune system and make you more susceptible to infection and other things, and your count may well drop with that. But the sort of acute reaction, I mean, if you had your blood count taken and it was 30, and I then told you to go up and down a flight of stairs 3 or 4 times, then took your platelet count again, it would probably be 40, just because you push platelets out when your heartbeat goes up. But as I said, more long-term stresses may well impact on your immune capability and may impact on your platelets. Ron, did you want to make any comment on that? Or?
Well, I think that emotions have an effect on us. I mean, we all know this really, have an effect on us all the time. And we, you know, like everything, you don't stay the same from one moment to the next. And as Adrian was saying, if you had your platelet count taken in the morning and you had it taken again in the evening, it would probably be different, even though you'd had a normal day, because, you know, it isn't, you know, the numbers that come through aren't also, I don't think, that definitive. I mean, if you've got a platelet count of 0, which is what I had, it doesn't mean that you've got absolutely 0 platelets. It's just that the machine has not been able to count enough platelets to get a significant number. Yeah. Yeah, do you want to say something there, Adrian?
I do. I mean, that's a very important point you raised there. I mean, my platelet count isn't as normal. If I had my platelet count taken on an hourly basis over 24 hours, it would fluctuate by 5, 10, 15. So someone with ITP, their platelet count fluctuates. So if your count is 25 this week and 20 next week, that doesn't mean to say your ITP is going in the wrong direction. It just means you've picked it at a time. So it's seeing the count going over a period in a consistent direction, say it's going down or it's going up. And the point that Rhonda makes about counting platelets is a very interesting one. The machines that count platelets or that do blood counts count them on size. And in severe ITP, a lot of the platelets are bigger because new platelets are bigger. And these machines often count these as red cells. So when you do special tests that actually identify platelets, you often find in maybe 20% of patients, the platelet count, when you do what we call an immunofluorescence test that recognize a platelet, in 20% it's higher than if you measure it through these machines. So if I have a patient with a count of 10 or 15 or 5 or 10 who has no bleeding problems whatsoever, I know that their count is not that low. I know it's higher than that because of the error, inbuilt error in the machines that we use to measure these.
Yeah. Coming back on the emotional side of things, I think that I think we all know that when you're feeling low emotionally, you feel low physically too. And a lot of people who have a trauma or a bereavement or any kind of thing like that, even the news that you now have ITP, which you never heard of before and nobody else has heard of, and you're now worried that you're going to die from some horrible disease that you didn't know anything about. And I've written about this in the Platelet, if you ever do read those articles about health and well-being. And so often when you are feeling like that, you are more prone to picking up illnesses. So you might get a cold or the flu or something, and you just really feel rotten and all that kind of thing, because your immune system is also tracking how you feel with your emotions and things like that. So it's really important to have in place in your daily life a situation where you've got some kind of routine where you keep yourself on an even keel. So some people do this through exercise, some do it through meeting up socially with friends, some do it through meditation or mindfulness or things like that. And I think that although we're not saying that, you know, you should do these things, I just think that within the health and well-being lifestyle that we're now all being encouraged to take up in every way, so that you're a reasonable weight, you don't drink too much, you don't smoke, all of those kinds of things are all going to add in to your health and well-being, which is sort of the buzz phrase now for looking after yourself and being sensible, really. And I think that you know, you can't go wrong if you're doing those things. And I think also if you do have any particular emotional problems that come up in your life, that it is really important to get help if you need help. I mean, the help might just be phoning a friend, talking about it to your partner, discussing it with your children, you know, discussing it with your GP. It might not be any great thing that you have to do, but if you're suffering really badly from something like bereavement, then it is important to go to your doctor and to find out if you need to have counselling or have medication. And I think that this is something that we must always be very mindful of, looking after ourselves, and that is not selfish. It's really important, because if you don't take care of yourself, you really can't take care of other people. So you're number one, because then if you're well and you're happy and you're able to cope, you're going to be a much better person to help other people and to live your own life with your family.
Thank you, Rhonda. Got two more questions like that. Diane and then James. Diane?
Yeah, hi. We're all sort of sharing quite a bit tonight. I wasn't going to mention this, but actually it's something that's really playing on my mind. Now, in December 19, I was really unwell. Breathing difficulties, aching all over. In fact, COVID, as we now know it. My hematologist was saying there's something really weird going on here. We don't know what it is. So I recovered from that. I had 3 months of what I would say was long COVID, difficulty walking even. I mean, I felt absolutely wretched. Now, fast forward, I've been on Romiplastin for probably about 4 years, and I'm on the maximum dose and probably getting an average of about 40-ish. Not great, a lot of bleeding. A little while back, swapped to another drug, and started to be very ill and developed blood clots on the brain. Now, I'm not an anti-vaxxer, but I am struggling mentally with making a decision about having a vaccine because of these blood clots. My gut instinct is telling me that I don't want to have the vaccine. I'm extremely frightened. I kind of rationalize and think, well, I feel that I got through what was COVID back then without any drugs, without hospitalization. So arguably, if I did get COVID now, I would be okay again. I mean, the platelets did drop at the time, but not so much that I needed to be hospitalized or needed any intervention other than the Romiplastin that I was on. So, I mean, I'm kind of in a real quandary, Adrian, as to what I do about this.
Most people would say that if you've had if you have a first vaccine and people had a clot like that, they wouldn't give a second vaccine. If you had a clot like that recently, almost certainly you would be advised not to have the vaccine.
Yeah, but my clots, Adrian, came from the other ITP drug.
No, but if you had a clotting tendency and you had a clot, then almost certainly you would be advised not to have a vaccine. It would be worth discussing with your either hematologist or whoever looked after you with the clot and ask their advice, because they'll know the full details, which obviously I don't know from that. But I mean, as a rule of thumb, if someone's had a brain clot recently, then we wouldn't give them. We wouldn't.
No. I've got several clots.
I would say that the brain clots have been almost exclusively associated with the AstraZeneca.
Yeah, I know, but I think hopefully you can understand it's quite a difficult decision to make.
Sure.
I mean, I'm being extremely sensible all the time, and I think I don't want to have it at the moment. I'm quite happy to kind of keep going and keep being very sensible.
I mean, the advice would be for someone with that history, as I interpret it, is that you would continue to take all the precautions.
Absolutely, yeah. I mean, I have discussed it with my hematologist, who's fantastic, got a wonderful relationship with him, got the utmost respect for him, but obviously it's very difficult for him to say yay or nay. I mean, we don't know. For me, it feels like it's a massive gamble that I'm not prepared to take just at the moment. I don't particularly want to travel. I've done loads of traveling. There's other places I'd like to see, but it's not a priority for me. So
I would entirely agree with you.
Thank you so much for that. That's kind of made me think that maybe I am doing the right thing just at the moment. Anyway,
much as I encourage people to have vaccines if at all possible, as I interpret your story, I would tell you to avoid it.
Yeah, thank you. Thank you.
Thanks, Diane. James? Just unmute. That's it.
I realised that we're running out of time. I hope I'll keep it as short as I can. I'm calling on behalf of my wife, actually, because she has had ITP, or actually Evans syndrome, since 1988. And in the last 6 years, she's been on Romiplastin, which has kept her stable. But there are two questions. One is that she takes a full vial, and oddly enough, over the years, time scale between taking having an injection has gone from 7 days out to 22 and 23 days. So what we have noticed is that her platelets, for example, we had a test on Monday, which was 17 days after the last injection, and her platelet level was at 488. I know that when we do the next blood test in, say, 5 or 6 days, it will be down to about 40, maybe 100 or whatever. So it fluctuates. I'm troubled as to whether or not it is advisable to continue on such a dose. In fact, I was intent on having a lengthy conversation with her hematologist, but we haven't seen him now for 18 months because of COVID. And it's quite difficult to discuss these things by telephone. But the second question, it relates to whether or not the use of the romiplostim for a long period of time, in my wife's case, as I say, I think 6, 8 years, whether it impacts on the bones, because I've noticed, she's now suffering from osteoporosis of the shoulder and the hip, and she has, what's the other problem you have? Anyway, whatever. And I did look at the side effects, adverse effects of romiplostim. I did mention damage to bones, and I wondered if there is any evidence of that occurring with extensive use of romiplostim, please.
No, there's no, but romiplostim has some side effects, but they're mainly, the most severe one is the problem with clotting, which happens in a very small percentage. There's a problem where it can cause sort of furring up of the bone marrow, but you can see that very easily on its impact on the blood count.
All right.
Any significant effects on the bones, osteoporosis, is just so rare, we don't know whether it's actually happening because people are aging rather than the drug itself. It's certainly not something that's consistent, and we've had patients on romiplostim now for 10 years plus without developing any new issues. So from that point of view, I would say I wouldn't be surprised if the bone problems are related to that. In terms of the increasing gap, what we try and do, and one of the issues with romiplostim is that once the counts are hitting sort of normal levels, we try and tail the dose off. We drop the dose, we increase the intervals with a view to ultimately stopping. And in about a third of patients, you can stop the romiplostim completely, and the patients go into a long-term treatment-free response. The count may be normal, it may be over 50, but if it's above 50 and they're not on any drugs, then that's fine, because you know she responds to it and she could always restart it again. But certainly, if you're having gaps of 3 weeks between the injections, there's a very good chance that by reducing the dose and increasing the gaps, you'll be able to tail off and see what level her platelet counts settle out at.
Okay, that's good. Thank you very much. Very helpful.
Thank you very much, James. Okay.
Thank you.
Mandy, last question before we move on. Thank you.
Hi. Firstly, I just wanted to say, Peter mentioning earlier on about the cardiac procedure he's having. If it's any reassurance, I had a cardioablation a couple of years ago, and I was really concerned about my platelet count, and having the cardioablation, my platelet count since I was diagnosed with ITP about 4 years ago is normally about 70. And the first thing when I arrived at hospital that morning, the actual cardiologist came and took my bloods himself and got those back before I then went ahead and had the procedure, and everything went very well, and it was all very well handled. So I just wanted to say that really in terms of reassurance.
Thank you very much.
Excellent, thank you.
Like I say, my platelet count is normally about 70. The only time, as far as I'm aware, it's dipped in the last 4 years to any significance is when I got influenza B about 3 years ago in December. I ended up in hospital for 5 days, and I was really quite poorly, and my platelet count definitely dipped to around 30. Ever since then, I've had the flu jab, and I'm first in line at Boots to get that in September, and I book in the first week it's on offer. in light of COVID, I just wondered whether, am I doing the right thing to continue and go and have that as soon as it's available in September? I know there's been talk about having a joint flu and COVID jab, and I just wondered what advice Professor Newland can give, because I would be, I think, a bit concerned about having both at the same time, and wondered what impact that might have on me.
It probably wouldn't have an impact, but I would certainly advise you to continue doing what you're doing and have the flu jab in September as before. I think we may well see a surge of flu this winter because there was so little last year because of the impact of COVID for a variety of reasons. But I would certainly encourage you to have the flu jab in September and then wait and see what they offer over the COVID. They may not offer a booster. I think they'll offer it to some groups, but they haven't made up their minds yet.
Okay, thank you. Finally, can I just ask, as I say, my platelet count's always been around 70. I haven't had it taken now for more than a year. In fact, it's more than a year since I had my last telephone consultation with my haematologist. The only thing I had noticed, is it petechiae, you call it, with the little bloods?
Yeah.
Would you expect me to be able to see any of those? The only time I've ever noticed them have been on my stomach and the little tiny red blood blisters. But I went to the doctors, they did a count, and it was, again, 70, 74. And the doctor said to me, he thought that's what it was. But then when I phoned the hospital to get some advice from the haematologist, I was told by the haematology nurses that he didn't expect it to be that with a platelet count of 70. So to be honest, I forgot about it. I monitored it and I've got on with things. And that was a good 6 months ago now. And I haven't had my bloods checked since.
Yeah.
Would you expect me to be able to see any signs with the count of 70 plus?
No. I mean, petechiae tend to occur when the count's less than 20.
Right.
And if you get them, you get crops of them, and they tend to be particularly on the lower legs and around the ankles, the shins, calves, ankles, and you see there are lots of ones like that. If you see a little red spot elsewhere and you don't have any ankles, it's unlikely to be these petechiae, and we wouldn't expect them at counts of 70.
Thank you.
Yeah, I did have it when I had a platelet count of 0, and I did have it on my legs, and it was so unusual. They brought all the doctors in. I've never had so many men looking at my legs. I also had it on my hands. I had it on the back of my hands, and I had blood blisters in my mouth, and I even had some in my eyes, which I was very concerned about. But yeah, it is quite, it's not that common, is it, Adrian, really? I mean, and you know, the doctors had never seen it before. I think a lot of them had never even heard of it, along with never having heard of ITP. But yes, there was this constant procession of people coming in to have a look.
I mean, certainly, I think Mandy's right not to have a blood test. We try and encourage people now to go on their symptoms and signs, i.e. if you've got a bruise, go and have a blood test. If you have a problem, have a blood test, but don't necessarily, if your count's been pretty stable, you have no problems, because by having a blood test, you get fixated by numbers. If you're normally running at about 70, but your count happens to be 6, you think, heavens, it's fallen. But if you went back the next week, it would have gone up again. So we're trying to say, go with how you feel. Don't be fixated on the numbers.
That's very true. And I definitely, when I was first diagnosed, I mean, firstly, I was terrified. And secondly, the numbers did freak me out, I must admit. And joining these calls and the conference and watching all the videos from the conference was so reassuring and helpful, understanding the condition so much more than I did before.
Excellent. Thank you.
Thank you very much. Okay, everyone. I think we call it a day. If you do have any questions, you can email us at the office, info@itpsupport.org.uk. In the next couple of weeks, we have got a couple of more of these sessions already scheduled. We've got the All Ireland one meeting next week. Anyone can join that one. And in a couple of weeks' time, you've got the Scotland meeting. So again, anyone can join that. Looking a bit further ahead, ITP Awareness Week in September. we're pleased to say we'll be kicking off the North East of England meeting, which is being organised by Tina, who I can see on the screen here, with one of the clinical nurse specialists from one of the North East hospitals. So that's taking place on the 20th of September. And then on the 22nd of September, we have Nicola Cooper doing a paediatric Zoom call as well. So there's loads going on. We've got other plans for later in ITP Awareness Week as well. And then October, we're looking for the Southwest of England meeting. We've just got to sort the date out. But it's looking like we might have Charlotte Bradbury. Charlotte's agreed that she can Zoom in on the meeting. So Charlotte Bradbury from Bristol. So fingers crossed for that. So once I sort out a date with Karen, hope you're okay, Karen, by the way, darling. We'll crack on from there. But any questions, please email them in. Thank you for your participation today. It's been an excellent meeting as always. And looks like we'll be carrying these on for a little while longer. Thank you very much. Thank you, Adrian.
Thank you.
Thanks,
everyone.
everyone.